time getting people here. Welcome everybody to our Berks Alliance Community Forum today. We're going to focus on internet connectivity as a social determinant of health. And we have a really expert panel that's going to be leading us through this conversation. I want to introduce John Weidenhammer, who is the chair of the Berks Alliance, for a brief introduction, and then I'll come back.
Hi, Dave. Thanks a lot for your work in setting up this. Really, I think what'll be a most interesting conversation about an important topic. And I also want to thank our presenters and panelists for the time that they've invested in this program. For those of you who don't know, the Berks Alliance is a collaboration of anchor institutions in Berks County, and we're focused on community development. And of course, the health and well-being of our citizens is part of that. And our mission really is to help improve the health, wealth, and education attainment of our community, and to work to make sure that there's an adequate supply of living wage jobs and also an adequate supply of people to fill those jobs, which is really consumes a lot of our time and our work. So again, delighted that all of you are participating in this conversation today, and I'm going to turn it back to Dave to provide us with the ground rules and maybe to tee up the conversation.
Thank you, John. We do have some ground rules that we apply to this. We ask you to try to keep your camera on, but your microphone muted during the presentations. We will be recording this and sharing that recording with everybody who registered for the event. We know there's some people who aren't able to be with us today, but will be watching the video at their own time. We asked you to use the chat function to submit comments and questions. We'll be screening those as we go along. We will try to get them answered either during the conversation, during the panel presentation, or after the formal presentations are done. We'll come back to those. Any questions or comments that we don't get to today, we will share with the presenters, and we will share their responses back with everybody who registered for the event as well. We have I think a great panel for this discussion. They've been, frankly, national leaders on this topic, so we're really lucky to have them be interested enough to visit Berks County virtually through this forum and share their insights and information with us. So I'm going to start by introducing Dr. David Ahern, who will do a brief presentation, and then we'll go to our panel discussion. We'll come back and I'll introduce the chair of the panel discussion, and he'll introduce the rest of the panel. David Ahern serves as a senior advisor to the Connect to Health Task Force of the Federal Communications Commission, the FCC. He's a behavioral scientist and informatics researcher and serves on the faculty of the Brigham and Women's Hospital and Boston Medical School. As a senior advisor to the FCC task force, he was co-chair of a public-private partnership initiative to co-create patient-centered technologies for Campton Center management in rural and medically underserved communities. He's currently taking a leadership role in the task force initiative to advance broadband connectivity as a social determinant of health, understanding the importance of broadband internet access for people, particularly those with health issues and health risks. So David, I'm going to turn it over to you.
Thank you, Dave and John. Let me make sure that you can see the screen. And it should be on full slide mode now.
Yes, it's there. Yep.
Perfect. Well, welcome and good morning. Thank you for the opportunity to present to the Berks County Forum today. As Dave mentioned, I serve as a senior advisor to the Connect to Health Task Force, and I'll talk about the work of the C2H, Connect to Health Task Force. The talk today is about the broadband health imperative. I think this will provide context and I think a good setup for the panel that'll be forthcoming. I have a set of slides I'll move through to make sure that I cover this material in the allotted time. There is a lot of detail, but most of this is available, much of it is available on our webpage. at the Federal Communications site, and then we'll provide those links. So just a brief agenda, I'll provide an overview of the work of the Connect to Health Task Force, which is a specialized unit in the FCC chaired by Michelle Ellison, the FCC General Counsel. Will focus specifically on the new initiative that I'm leading, Advancing Broadband Connectivity as a Social Determinant of Health domain. A few slides about the benefits and future trends in telehealth that I think are relevant as it pertains to broadband connectivity, and then leave you with some key takeaways. So first, the vision of the Connect to Health Task Force was formed in 2014, and it's everyone connected to the people, services, and information they need to get well and stay healthy. And the point here is it's not only about healthcare delivery or healthcare services, it's about the pursuit of health and promoting health and wellness and prevention. We think broadband connectivity has value in both of those areas. In terms of the overview, that the task force since 2014 continues to serve as the umbrella for our FCC health-oriented activities, specifically promoting effective policy and regulatory solutions that encourage broadband adoption and promote health IT through its initiatives and interagency work. And obviously, all of us have become aware of the significant disparities in health inequities, in part related to the COVID pandemic, but we've known, those of us in the healthcare space, for many, many years. But now it's really a significant focus and top of mind for many folks in the healthcare space, and that's good news. The question is, can we leverage broadband connectivity to close the digital divide in health and ensure that we want to ensure the FCC stays ahead of the health technology curve and is part of enabling broadband connectivity to become available to all of the people in this country. That's the goal of our chairwoman, Rosenworcel, to make sure that everyone has access, 100% access to high-speed broadband. So the broadband health imperative is the future of public health is fundamentally premised on the widespread availability and accessibility of high-speed connectivity, both by providers, by public health departments, and consumers alike. This sort of graphic represents that, multiple domains of the broadband health imperative, and we continue to advance the work, particularly this notion now with referencing the health inequities, is that digital equity is critical to achieving health equity. And I'll talk more about that, and I suspect our panel will address it as well. We know there's a broadband health gap that exists today, despite efforts now to both invest in broadband infrastructure deployment and increase access to broadband through support programs that the FCC has provided. We know that there are still gaps, and through the work we've done in the task force, we've demonstrated that communities that need broadband for health the most, unfortunately, tend to have it the least. And that really is an imperative for us to make sure we do more to get people access where we can. I want to talk about the new initiative, which is Advancing Broadband Connectivity as a Social Determinant of Health domain. And the word domain is important, and I'll restate it actually with another word we think is very important. It's really advancing broadband connectivity as a distinct social determinant of health domain. Currently, as I'll speak to this, it does exist in the context of the Healthy People 2030 initiative within HHS, but it's an objective within the Neighborhood and Built Environment domain, which is one of the domains, and this lists sort of what are other social determinants of health that we now acknowledge. There are conditions and places where people live, learn, work, worship, age, and play that affect a wide range of health functioning, health outcomes. And the neighborhood and built environment is one in which broadband, at some level, logically fits with it. However, we think that there's more to that, and we want to elevate the discussion, and that's the reason for promoting broadband connectivity as its own domain or a distinct domain. And why are social determinants of health important? Well, they've been important for a long time. Again, it's not unlike the inequities and health disparities issues become top of mind. We recognize that 80 to 90% of a person's health and well-being is related to these traditionally non-medical factors that account for health status and health outcomes in many ways. So we believe it's really important that we focus on these social determinants of health. This is a key slide for us in the task force. And hopefully the message will come clear to you, and hopefully there's consistent agreement here on this. We've generally found that to be the case in our work. The broadband connectivity is more than a tool, it's more than infrastructure. And some of the research that we've done has shown that when we look at broadband in relationship to health and health outcomes, we actually see a positive correlation. That increasing access and adoption increases better health outcomes. And indeed, we see adoption that has even greater relationship in a correlational way to health outcomes. And then even in poor health areas, such as in the so-called diabetes belt, in some of our studies, we found increasing quintiles of broadband access is correlated to decreasing rates of diabetes prevalence. And then the work I've done in the Launch Collaborative, which is the public-private partnership around cancer care, we found a relationship between broadband access and lung cancer mortality. And that's a paper that we'll be submitting for publication soon. And what we've really found in some of the statistical modeling of this is that if you can, when we look at broadband access in control for other social determinants of health, we find that broadband access has both an independent contribution and it also serves as a catalyst of other social determinants of health. So think about that for a moment. And this is where the super determinant of health, a concept emerged from our work, that we think that broadband access, and why again a domain, because it adds value and increases the likelihood of the uptake and benefit of the other social determinants of health. So this is the sort of basis of what we're now doing in this new initiative. We want to elevate the discussion. We want to have conversations with our fellow colleagues in other agencies of the federal government, the public sector, private sector. And the work is really to inform future FCC policies and programs, the Broadband Universal Service Fund and telehealth communities. We really think that this is an important focus to increase uptake of broadband, both access, adoption, and ultimately use. And the question that we've kind of encountered that we hear now, I should say, generally we get a very positive response to the idea that broadband is a social determinant of health. Gee, yeah, that makes all the sense in the world. Of course it is. But when talking about a domain, the question becomes, why is that important? What are the potential implications? Well, we think it could have transformative implications for national policies and programs that could emerge. We think it could improve and increase access to effective and efficient medical interventions. It could certainly further to bridge the digital divide. And this is the really important point back to this digital equity is health equity concept, which is that, there is the concern that if you do not have access, and increasingly so, and if communities of color and other underserved communities that previously didn't have access don't get access, then we're going to increase the digital divide. We cannot let that happen. We have to flip the script, if you will, and actually engage communities with broadband to make sure that they get access to effective treatments and access to high quality care. So I'm going to give you a brief clip. Let's see if how this works. This is an excerpt from the one of the videos of the fireside chat session for our public event that occurred, the first FCC Digital Health Symposium on March 3rd of this year. And this is my interview of Dr. Don Berwick, the former administrator for the Centers for Medicare and Medicaid Services. And I want you to hear Dr. Berwick's commentary in response to my question. So it's a brief segment. Let's make sure that, let's see if this works here for us. It'll take a moment to come up. The conversation about broadband connectivity goes beyond it being infrastructure only. When we think about it more broadly, we think about it in terms of access, adoption, and use. There's sort of three facets of broadband connectivity, each of which can, in their own way, have a value proposition. Does that trigger any other thoughts for you here in our remaining minutes?
Yes, it does, David. Thank you. I learned a lot from listening to Karen, the viewpoint that the task force and the commission are having. I'm just pretty excited by what Karen has taught me already in the short time I've learned from you. But I think the mentality change that I think the task force has and encouraged them to have is not to think of broadband as a way to automate the existing with what care and pursuit of is. I think that it doesn't have also a conversation, rather thorough redesign of the nature of care. I know that it's kind of vague, but I mean, let's get a system that's not just railroad tracks with current care system. And I think that's really
I know that might have been a bit choppy. Bear with me for a moment while I move on here.
you stay in a hotel now without getting.
There we go. That I'll post the link to that video. It's on the FCC YouTube channel. The entire, we have videos of all the sessions, including that fireside chat session from the March 2nd event. I'll put that in the chat so that you can hear the full conversation. But the takeaway from Dr. Berwick was, let's not look at broadband only as rails for the existing healthcare system. Let's use broadband connectivity to transform healthcare and transform health, the pursuit of health. I love the way you frame that as something new in the future. And really, we like to talk about the ecosystem of health, not just the healthcare delivery system. It's communities being able to connect to each other, caregiver support, families that can share experiences together with communities, public health agencies. It's about prevention as much as it's about changing healthcare delivery. But in my remaining minutes, let me just highlight a few things around the telehealth, benefits of future telehealth. Obviously, the COVID telehealth, the COVID-19 pandemic really propelled telehealth significantly, and it caused major disruptions in traditional healthcare delivery systems. But we saw the value proposition of having the ability to have virtual care. And unfortunately, many people, because of concerns about infection, didn't get the treatments they needed. We have concerns about the long-term effects of that. We think telehealth and telemedicine, though, can really help mitigate some of these disruptions that occurred and also help us in the future, right? That we don't want to go back to a model that it's, bricks and mortar, you got to go to travel long distances. You can do a lot of healthcare through virtual care, and we think broadband is going to be essential for that. And the clinical value of broadband-enabled telehealth is now emerging pretty significantly in the work I do at the Brigham and in the hospital systems. It's both synchronous and asynchronous communication can enhance patient engagement. This movement of remote patient monitoring, moving care more to the home and using technology devices, connected devices, and the Federal Communications Commission through its telehealth fund supported increasing access to connected devices. I do research in digital phenotyping and passive sensing to use information we can gain in day-to-day movement using your phone and using sensors. It's just tremendous opportunities there. And then finally, machine learning and artificial intelligence will be able to enhance effective treatment, again, for telehealth and virtual care. So what is the future of telehealth? And end with this. As we emerge from the acute phase of the pandemic, policymakers now face the challenge of building on and sustaining telehealth reforms. And we need collectively, I think, as a society, to ensure that we continue to support these new models of care. So the key takeaways, last slide. Broadband connectivity is not just a nice to have, but a need to have, crucial to enabling telehealth and telemedicine and improving health outcomes. And recognizing broadband connectivity as a distinct social determinant of health domain can serve to promote digital equity and health equity. So with that, I will turn it back to Dave. Thank you for your time and attention.
David, thank you. And it's, I have to say personally, it's very exciting to see the FCC so heavily engaged in this topic. It's great. I'm going to do a little bit more context and then we're going to move on to our panel discussion. A couple things that are happening in Berks County that I think it's worth noting for our audience. There is a group working on broadband connectivity in the county. One of the lessons that we learned in COVID was how critical and important this was. So we do know that there are places in Berks County that don't have access to high-speed, reliable internet service. But we also know that there are people who are challenged by the technology, by by the finances of it, by the having to know how to navigate the system. At the same time, both of the major health systems in Berks County are very interested in issues related to the social determinants of health. There's been a lot of focus in both those organizations on things like housing and how housing affects people's health, food access and how that affects people's health. And there's a beginning understanding, I think, in the county of how broadband connectivity affects people's health. So we're hopeful that this conversation today will be helpful in stimulating that broader conversation in the county about both the connectivity issue and the access to care issue. And so with that, I'm going to turn it over to Renee Squatchy, who is the first ever vice president for digital health at the Consumer Technology Association, which is a large trade association, 1,500 member companies representing all aspects of the technology sector. He provides guidance on key technical and regulatory issues relating to consumer digital health and wellness technology products, services, software, and apps. And Renee is going to be running our panel discussion. We have a number of other people who'll be joining him. So Renee, to you.
Thank you very much, David. So glad to be here. We did a version of this at the same symposium that Dr. Hearn just mentioned about 6 months ago, so I'm happy to be back. I think talking about a very important issue. And so before I sort of get to our panelists, I think we need to set the stage a little bit here. And Dr. Hearn mentioned some of these topics in his talk, but as you all know too well, look, not all people living in the United States have the same opportunity to pursue a healthy lifestyle. And we're going to talk a little bit about some of the barriers and why that is the case in our discussion today. But I think it's very useful to think about the fact that we may be in the midst of a transition. Dr. Hearn talked about COVID-19, but I think even before COVID-19, I think how healthcare was being delivered and consumed has changed dramatically as technology advances. So many stakeholders, some of whom are represented on this panel, are developing and deploying very innovative digital health tools for use everywhere, from the hospital to the home. So there's a lot of incredible innovation occurring. And I think, as with all other technological innovation, it has a tremendous potential to better democratize healthcare in the United States. And we're going to be talking about not just telehealth, but a whole bunch of other digital health solutions that are being introduced, that are being used in clinical care. But the issue and what brings us here is that much of this innovation only works, and it works most effectively with high-speed connectivity. Because if a person is not connected, that person is at risk of not being able to access the latest and high-quality care. So that's setting the stage for this great panel. So instead of me introducing the panel, I think what's most useful is allowing the panelists to introduce themselves. I'll start with Dr. Broadband. Please introduce yourself, your background, your role at your current organization, and the focus of your organization.
Thank you, Renee. And good. I guess it's still good morning for a few more minutes anyway to everyone in Berks County. Thank you for the invitation. It's a pleasure to be here. So I'm Karen Ruban. I'm a pediatric cardiologist at the University of Virginia, also Associate Dean for Continuing Medical Education and Director of the Center for Telehealth. My engagement with telehealth began in the 1990s when as a traveling pediatric cardiologist, because we would drive all around the Commonwealth of Virginia to see children with complex congenital heart disease, it dawned upon me, especially after hearing other luminaries speak about this, the opportunity of telehealth. And so, because I might drive to far southwest Appalachian, Virginia and see a patient, be there for 2 days seeing patients, and then when I would go back to the University of Virginia, the patients would either have to travel to me or not get care at all. And so we were early adopters of telemedicine, began our program around 1995, and began to scale, faced many public policy challenges, not the least of which was lack of broadband communication services. And we were seeing patients in community facilities, these because of Medicare and Medicaid regulations that we had to see our patients at a clinical site. But even that was a challenge without broadband. And so I'm so grateful to the FCC for the work that it has done to support universal service and access to care. Anyway, so we, gradually we increased the number of activities, the types of things. We began remote monitoring in the home, but nothing transformed us more quickly than the COVID-19 public health emergency. And, as an academic medical center, we have missions of clinical care, education, research, and public service and outreach. And it is hard to turn a gigantic institution. It's like a giant aircraft carrier trying to turn it on a dime. Hard to do, but we had to do that during the public health emergency. And so I'll look forward to the conversation to share, how we did that as a system, but it didn't happen quickly. And we recognized early on that many patients face significant disparities, and in particular, lack of broadband communication service has been one of the greatest disparities that we face. And we'll talk about that more. So thank you for having me, Renee. Thank you.
Excellent, excellent. Dr. Thacker?
Sure. Good morning, everybody in the Berks County, Pennsylvania, from Chapel Hill, North Carolina. My name is Samruddhi Thacker, and I am delighted to be here. I'm trained as a physician, health services researcher, and a public health professional. Today, I bring perspectives, also as I call it, a human being who survived the pandemic so far, and learned a lot through the process, learned many things, and I believe all of us share, that experience. That's a common experience that bonds all of us. I work currently at the MIDER Corporation. We support primarily the federal government. We also work with the state and local government, as well as some regional entities, but primarily we have the privilege to support federal government across multiple agencies, including Health and Human Services, but also beyond. For example, Department of Defense, just giving an example. So here for the purpose today, I consider it my privilege to bring a perspective I have developed over time during the past 3 years of supporting the Federal Communications Commission. In my role currently at MIDER Corporation, I lead a project in support of the FCC. David Orn is one of the colleagues I have the privilege to get to know and support over the years. There are others at the FCC I support as well. And through the support I have provided to the FCC, work with them collaboratively, I've also gotten to meet others, including Renee and Karen and Michael Crawford. So very delighted to be here. Glad to bring the perspectives that I can share, and eager to learn alongside all of you. Thank you.
Great. Michael?
Greetings, everyone. Thank you for the opportunity to be here to talk about this meaningful topic, not only to Berks County, but for the broader global community. I mean, broadband has just become an essential component of our daily lives. I am the Associate Dean for Strategy, Outreach, and Innovation at Howard University College of Medicine, also the founder and executive director of Howard University's 1867 Health Innovations Project, which was established in April 2020 with an express mission to partner with researchers, entrepreneurs, technologists, and corporate partners to tackle challenges confronting distressed communities from a digital health perspective. So we really look at identifying digital health solutions that can do 4 things: help improve access, affordability, health outcomes, as well as the patient experience for those individuals living in medically underserved communities. Since our founding, we have established several partnerships. One, ARP Innovations Lab is a partner where we look and explore health and data solutions to improve the health and well-being of 50 plus, with a special emphasis on those that are underserved. HHS in the realm of sickle cell disease, a local housing authority in the Washington, D.C. region, where we look at this next iteration of healthcare, which is bringing care to the home, and how we identify solutions to make it more convenient and readily available for individuals aging and living in complicated communities and environments. And lastly, we have several corporate partnerships that we are working on to identify different solutions, innovative solutions to improve access to healthcare. Like my colleagues have mentioned, we all have worked through the pandemic, and we've seen the evolution of how we are delivering healthcare, especially in the area of telehealth. But we'll talk a little bit more about other digital health solutions that are having an impact on urban and rural environments, not only here within the United States, but globally. And then the last piece I would say is that with all of this change and institutional knowledge that we now have from the pandemic, I would hope that we will continue to move forward with these innovations and reimagining how we are delivering healthcare, because as I commuted into work yesterday to Washington, D.C., I recognized that the traffic was just as bad as it was prior to the pandemic. So what we are seeing is a regression to the mean in certain areas of our life. And with this particular aspect, the topic that we're talking about right now, we have to take advantage of this opportunity to do some things differently.
As you can tell, we've got a phenomenal panel, great perspectives from all across the ecosystem. So Michael, let's stick with you. You talked about the pandemic, and we talk about the pandemic having catalyzed a lot of digital health and emerging technology use. Can you discuss how your institution was able to catalyze the use of some of these tools, and also talk about some of the tools beyond telemedicine, telehealth that you found useful during the pandemic?
Yeah, I'll start with telehealth because that's the most obvious use case. During the pandemic, I was a chief administrative officer of Howard University's faculty practice plan. So as the news began to sprinkle in regarding the COVID-19 pandemic, every healthcare organization throughout the world started to shift their mentality to determine how they could continue to maintain healthcare services, especially for their patients that have critical need. So as a leader of our health system, one of the things that we quickly had to do was to ramp up our telehealth capabilities. So within a 4 to 6 week period, we went from single digit adoption of telehealth services to 80% adoption of telehealth services over a course of 6 weeks. This required a number of individuals, change management, transformation, and innovation for this to occur within a short period of time. And as you all know, working in an academic setting, nothing happens fast. So this was a monumental task, and it was revolutionary that we were able to do this within a short period of time. But a couple lessons learned from ramping up telehealth services, what we quickly recognized from a workforce perspective is that digital literacy was a huge challenge, even amongst our workforce. So we talk about the end user being the patient and the caregiver, where there's some digital literacy gaps. There were some significant gaps on the workforce side amongst our health professionals, our providers, our auxiliary and administrative staff that we really had to bolster within a short period of time. We recognized that we didn't have the systems and processes in place to facilitate a robust telehealth program. So we had to put all those policies, processes, and systems in place to facilitate the scale and deployment of a robust telehealth solution. And then lastly, we recognized that our patients didn't necessarily have the hardware and the software to be able to engage in telehealth encounters. And a large part of that was broadband. Some folks had broadband access, but they had insufficient broadband access to be able to have a efficient telehealth encounter. So what we found, particularly with our underserved patients, is that they were reliant on their mobile phone and their data plans, or in some instances, audio calls. What we found in the pandemic is video calls tended to be more efficacious relative to an audio call. Provider was able to lay eyes on the patient, self-assess, as opposed to a patient self-reporting through an audio mechanism. So we found that medically underserved, poor patients were using the audio component relative to the video component, which was a challenge. And that was centered on broadband, having unaffordable data plans, or relying solely on their mobile phones. Then we, as an organization, began to pilot other digital health technologies because this was an opportunity for us to explore how we would leverage these types of technologies to improve access. And we did that under the auspice of our 1867 Health Innovations Project, which is our digital health innovation program. We look specifically at some of our chronic disease populations, diabetes in particular, where we knew that this patient population was struggling with medication adherence. So we began to search for, through some of our partners, innovative digital solutions. One that we used was a robot that dispensed medication, had facial recognition capabilities, natural language processing, and some telehealth capabilities. And we deployed that solution within the home through an IRB sanctioned clinical pilot. And this population was primarily digitally naive. And I'm defining digitally naive as individuals that had limited exposure to the internet as well as digital solutions. What we found when we deployed that solution to this type 2 diabetic population, that over the period of time that we conducted that clinical trial, medication adherence increased exponentially, quality of life factors increased, as well as hemoglobin A1C levels improved. And a key component to the use of this device was the caregiver. What we found that folks that had a lot of success with these devices had some sort of caregiver, either a partner, a daughter, a son, a niece, a nephew, to support them in this journey. Those findings allowed us to scale this device, scale this clinical pilot to reach more people, to give them the opportunity to better manage their health condition. The last piece I will mention is a lot of our patient support groups moved online. So we began to pilot whether or not online patient support groups were efficacious relative to in-person groups. And what we found through an open source format with a population of type 2 diabetics, that crowdsourcing individuals online gives folks the opportunity to, one, improve the way that they manage their condition. Secondly, can it help them improve their medication adherence as well as quality of life factors? And that became a tremendous opportunity for us to continue to work with patients in an online format when they were unable to come into the institution in a brick and mortar structure. We're now moving that pilot to what we call a closed source Howard group, to determine whether or not a community curator, what we call it, which is typically a nurse practitioner that is leading that group with patients that have familiarity with one another, can demonstrate the same results as this open source group. So we're looking at that, and we're also exploring virtual, augmented, and mixed reality solutions, which have been proven to have a tremendous amount of effect in pre-surgical planning and remote patient monitoring. Devices have been deployed during the pandemic that help with assessment as well as diagnoses in nursing homes and assisted living throughout the country. We're exploring applications in that area. Sensors that passively and actively monitor, they can monitor activity within the home. Dr. Hearn talked about this. Monitoring. And then that facial voice recognition and looking at data and inflection points to determine whether or not we can determine whether or not someone has early signs of a disease and whether or not the disease is progressing in a way where we can deploy staff members for intervention and early detection. So there's a lot of exciting opportunities that we are exploring and that we have been working on, and looking forward to talking a little bit more about that.
So Michael, before I turn to Dr. Raban and what the University of Virginia was doing, could you quickly talk about, you talked about 1867 Ventures formed in April 2020. If the pandemic had not happened, how much of this digital innovation and exploration would have taken place at Howard University?
Well, it's a great question. We were working on forming 1867 prior to the pandemic. What we found is with the pandemic actually helped accelerate the work that we were doing. It expanded the profile and platform of the work. Folks were more interested in supporting the work internally and externally in terms of the work that we were doing. We started out with a basic premise. Could technology be a great equalizer in closing the gap in healthcare disparities and health equity? That's when we started prior to the pandemic. Then the pandemic elevated this discussion related to health equity and health disparities, where it became not only a national conversation, but a global conversation. So that made the work that we were doing even more meaningful, than what we were doing prior to the pandemic. So we have had a number of individuals reach out to our program to talk to us about how do we partner across different digital health domains so that we can, one, validate some of these solutions and have real world evidence, not only in high functioning populations, but in populations that are under resourced. We can actually have some data, some evidence to support the work in this area. So if there is another institution in different parts of the world that are thinking about working with distressed or underserved communities, that they will have some evidence and data to support their business models and use cases to move forward.
Excellent, excellent. So Dr. Raban, could you walk us through the University of Virginia's experience during the pandemic, particularly from a digital health perspective?
Oh, sure. Thank you. And it's always wonderful hearing Michael speak. I mean, I just am in awe of the work that you've done. So just before we get to the pandemic, you know, we had engagement across more than 60 different clinical disciplines at UVA prior to the public health emergency. And we had innovators come to us to say, hey, I'd like to do X, Y, or Z. So we had already deployed, for example, mobile digital mammography to underserved communities, because based on public health data, we knew that in some of our rural and underserved communities, the incidence, for example, of breast cancer might be the same, but the outcomes were so much worse because of lack of providers and lack of access. So, you know, it was our fervent desire to try to address some of these challenges with digital solutions. Another thing, screening for diabetic retinopathy. Every diabetic patient is supposed to have an annual eye exam, and yet they don't for a host of different reasons, whether it's being uninsured. Thankfully, Virginia expanded Medicaid, or whether it's because there's no ophthalmologist nearby. And so our ophthalmologists deployed systems where they trained community providers to capture the image of the retina without necessarily having to put drops in the eyes to dilate the pupil, and send the images back digitally to our ophthalmology team who screen the patients, because diabetic retinopathy is the #1 cause of blindness in working adults. And I might add, our Medicaid program spent a lot of money on the aged, the blind, and the disabled, so why not prevent it? So we had to work in the public policy sphere to ensure coverage so that these services could be provided. And so in 2019, because we did have pretty considerable engagement already, but we didn't have an enterprise-wide platform solution integrated into our electronic medical record. And so in 2019, we embarked at the request of our CEO upon strategic planning for virtual care at UVA. And all the things that Michael has spoken about, you know, we tried to tackle all of it and came up with a phenomenal strategic plan. And we had new leadership arrive at UVA in early February 2020. We completed our strategic plan in the end of 2019, and I met with the new EVP and I said, here's our strategic plan for virtual care. And he was like, whoa, I've got to get used to this institution. I have to understand the finances a little better, but yes, we're interested. 2 weeks later, COVID-19 happened. And of course, almost everything that we proposed was adopted. Some of it was adopted because thankfully we were able to get grants to support it, but we massively scaled our remote monitoring program, because we knew that our patients were not able to come in as often, and they didn't necessarily need to come in as often, and they didn't need to be exposed. We launched virtual urgent care. We didn't have such a program. It was in our planning process, but we didn't have that. Well, people didn't want to come to the emergency room for risk of exposure to COVID. So we started virtual urgent care, and then we also began remote patient monitoring for COVID-19 exposed or COVID-19 positive patients, working again with both patients in their homes as well as community partners. So people who lived in congregate care settings, such as long-term care and skilled nursing facilities and correctional facilities, were exposed to massive amounts of COVID-19. And so we began the remote monitoring program in those settings as well, and helped us to manage patient care from pre-hospital to post-admission. And then even within our hospital itself, we deployed virtual care solutions to limit exposure of our health professionals. We created virtual PPE. Actually, we had created it in 2015 because of the Ebola outbreak. We are one of the state's special pathogen hospitals. So we set up our our special pathogens rooms with technology so that our providers didn't necessarily have to don and doff all that expensive and in short supply personal protective equipment. We had that originally in 5 beds of our special pathogens unit. We deployed it to 180 beds across the health system and across the emergency department. So, you know, we took the challenge of what we could do quickly. And then the other piece that we did was we adopted an enterprise-wide, where Epic is our EMR, enterprise-wide solution for video-based services through MyChart, which is our patient portal. And we chose a particular vendor because it operated nicely at low bandwidth, because we recognized that so many of our patients didn't have sufficient bandwidth. So a host of different solutions born of need. We're still a work in progress, I would say. We are continuing to work with innovators who come to us with an idea. And we also look at health status indicators and broadband adoption across the Commonwealth of Virginia. So we've worked, again, we're a state institution. We work with the Commonwealth of Virginia, with our General Assembly, with our Medicaid agency. It's a partnership that wouldn't happen if we didn't partner. Free clinics, community health centers, and of course, patients within their homes. So sort of a quick overview in the transformation space.
Boy, between you and Michael, I mean, just phenomenal work being done. I congratulate you both. I just want to turn to Dr. Thacker and your work supporting the FCC. Do you have a perspective on digital health, emerging health technologies vis-a-vis the pandemic?
Absolutely. Thank you, Renee. So a couple additional points. I, of course, concur, and I, share in the enthusiasm and excitement that Karen and Michael shared based on all the work they have led, and of course, you as well, Renee and David. So I tend to, and my guess is many people on this call sometimes find themselves going back to at least the same place I tend to go back to in the last 2.5 or so years, which is back to March 2020. So in the organization that I work and in the role I have, primary role I have to support the FCC, a lot of conversations back on March 11th of 2020 revolved around, the work we were doing, how important it was, but we did not have this sense of how game-changing the work that we were doing, I had the privilege of doing in support of the FCC was. And what I believe last 2.5 or so years have done is bring it to the forefront. We no longer find ourselves, in the minority. We no longer wonder in terms of whether connectivity is important. I would suggest, I think, broadband connectivity includes the word connectivity. So as somebody who is trained as a physician, who likes to care for people, help get them better and healthy, I always think of, we all agreed even before broadband became the in thing, that connectivity is important for human beings, or for all living beings, I would suggest. And so what broadband connectivity enabled us to do, especially in the context of pandemic, was to either pivot, either adapt, or either kind of, get out of the connectivity business. In that I would suggest those of us who, back March 2020, and even, a lot of us were well connected to people, but also to broadband connectivity even before then. But those of us who didn't pivot, there are multiple reasons why individuals, families, communities, counties, regions cannot pivot, could not pivot. But those of us who were able to pivot, those of us who had the conditions to pivot, I think essentially how we did what we did, whether we connected to other people, whether we stayed interested and engaged in work, whether our professions survived, how we spent our time to entertain ourselves, how we worshipped, all of those changed. And I would suggest the work that I have had the privilege to support the FCC most recently last 3 years, would not have survived, would not have continued had we not had connectivity. And in some ways, had the pandemic, however unfortunate, however I would suggest preventable, some of what we've observed has been, it's been a game changer in terms of all of us at least recognizing that, it's not an option or optional or a nice to have. Just like connectivity between people, I think we don't debate about it. It's needed, it's essential. I would suggest that's one of the key lessons I have learned personally and professionally, which is just like people-to-people connectivity is essential, broadband connectivity is essential. It makes the connections happen, and it makes the connections happen and makes the connections continue, which then allows us to pivot and embrace some of the challenges that 21st century will continue to bring our way, and help ourselves, help each other, and build more resilient communities and more resilient, hopefully, our country as well. So thanks, Renee.
Sure, and I think that's such a great point, because as more and more healthcare becomes technology enabled, connectivity is going to be key and essential, right? And so we're going to sort of get back to this issue a little later, but Dr. Raban, I'm going to get back to you, and I really want you to be fully honest about the current opportunities and the concerns you have about this increasing reliance on digital health solutions that is powered by connectivity, and how that may impact vulnerable or underserved communities, particularly in rural areas.
Well, as I mentioned early on, we started with our program in rural areas of Virginia, and we relied very much on the FCC to help us to connect, again, facilities, because that's where the policies were focused on. In other words, patients had to be at a facility to access telemedicine services. And there are many models of telehealth, I might add. You've heard this, we've referenced this. So it's not just synchronous video-based telemedicine, it's also asynchronous models such as e-visits and store and forward images, like the diabetic retinopathy program, where you capture the image and you send it for a later review, and then the broad range of remote monitoring tools. So the public health emergency clearly demonstrated the value of telehealth across all these clinical disciplines. I love FCC Commissioner Brendan Carr's analogy. We transformed from a blockbuster model of care in which patients would come to us as health providers to a Netflix model in which we're transported to the patient. And these federal and state policy waivers have contributed to the transformation, but we could not sustain this if they are not made permanent. And some of these are still a work in progress. So we do worry. A lot of these decisions are made by the states. Medicaid expansion is managed by the states. Telehealth services provided to Medicaid beneficiaries are managed by the states, and low-income individuals, are cared for through the Medicaid programs. Some of these requirements are going to be at a federal level. Medicare, there's something called the 1834M restrictions in the Social Security Act, which were operative up until the public health emergency, which required that a patient had to go to a facility to receive telemedicine services, and at that to only a rural facility. So those are real challenges. Fortunately, the waivers have allowed us to scale, and most of the states have passed, or many of the states have passed legislation for commercial payers and for Medicaid, but we still remain anxious to see what the federal government will do with Medicare. So to get back to the issue of underserved patients and broadband, I'm going to hearken to some Pew Research data that in 2021 reported that 80% of white adults report owning a desktop or a laptop, compared with 69% of Black adults and 67% of Hispanic adults. 80% of white adults report having a broadband connection at home, much less so for Black and Hispanic. 38% of patients with a disability don't own a laptop or a desktop computer, as compared to 19% without a disability. Geography clearly are significant obstacles. 28% of rural Americans don't have home broadband, as compared to 11%. And 24% of adults with household incomes below $30,000 a year don't own a smartphone. And 43% of low-income adults don't have home broadband or a desktop or laptop computer. So these are really significant issues. And we've helped to scale some of this work with federal grants and state grants. So we were awarded an FCC Connected Care Pilot Program award last year, which enabled us to provide not necessarily the device. We had additional funding for devices, but connectivity. So these devices are configured with cellular connectivity so that patients can have remote monitoring, even if they don't have home broadband. We just have to find all kinds of solutions to address the challenges our patients face. We've also deployed, in addition to the iPads that we sent to the patient's home with cellular connectivity, for those patients who have their own mobile phones that do have connectivity, we have a bring your own device model where they can just download an app onto their phone. You know, it's trying to find solutions that work, but these are clearly challenges. We, I think it was Michael who mentioned, maybe it was Dr. Thacker who mentioned, you know, audio only and it's important, audio only when you don't have access to the higher quality telemedicine service, audio only is important, but you know, a picture is worth 1,000 words and a video is worth even more. So we want to see everyone connected. We want people to have the ability to access care where they are. And it takes partnerships between healthcare facilities, between academic medical centers who conduct a lot of the research in this space, federal agencies, state agencies, and our legislators. So it's a work in progress, but I think there's a lot that can be done. The other thing that we found also, Press Ganey, which does analysis of patient satisfaction, also now has telemedicine patient satisfaction. And what we have found is that those who don't have good connectivity are not particularly satisfied with their telemedicine experiences. So again, it behooves us to push that broadband out to the home of the patient, make it affordable, find solutions that work even at lower bandwidth, certainly until we have 5G everywhere, and to get our policymakers on board as well. I've been very grateful to the Virginia General Assembly, which I lovingly refer to as the Generous Assembly, because they have supported a number of initiatives, and I urge you and your healthcare systems in Pennsylvania to work with your legislature as well. But our General Assembly has codified and required the commercial plans to pay for telemedicine services. It codified home as an eligible patient originating site. Therefore, the payers must pay for telemedicine services in the home. It codified Medicaid coverage of telemedicine a long time ago, but now Medicaid coverage of remote patient monitoring and others. Oh, and it recently codified the process by which community paramedicine can be implemented for Medicaid beneficiaries and pay the EMS agencies for supporting telemedicine, because the EMS agencies are only paid when the patient's transported to the emergency department. And we want to provide care preventing ED visits. And so we're working with EMS agencies to bring those paramedics to the home of the patient. And you need that broadband again at the home to make it work. So I'll let others comment as well.
No, that's excellent. And just so everybody understands, I am monitoring the chat, but I want to get through some preliminary questions, and I promise to get to as many of the chat questions as I can. So Michael, turning to you, and you and I have talked about this before, when you hear the words broadband and connectivity, and I do this too, we tend to think about rural areas in the country. Maybe you can walk us through why these challenges are just as critical in an urban environment such as Washington, D.C.
I think Karen highlighted some of the challenges in rural America. And what some folks don't understand is that the same challenges apply in urban America. So there are some unique challenges to geography in rural America and urban America. And then there are some similar challenges. And I'll start with some of the similar challenges. What we all recognize in urban and rural America, that broadband is expensive. Right? A lot of people can't afford it. So while we talk about access, the other metric that a number of folks talk about is adoption. What is the adoption rate of individuals that are poor and low income and rural and in urban America? That number is very similar. We also talk about digital literacy. Digital literacy is a challenge across the country, regardless of your socioeconomic status. It is a challenge in urban and rural America. So even when you have access, it is sometimes difficult for populations to optimize the use of broadband to receive information, to help them make informed decisions, and also to analyze how they want to, where and when they should receive care. In urban America, as I mentioned with the traffic I talked about, There are a number of workforce shortages. So if you live in a part of Washington, D.C., which is an underserved community, there's a great chance if you're a cancer patient, you don't have access to an oncologist or an infusion center within your community. That means that if you want to have a consult, it will require you to drive across the city or take public transportation, which could be up to 45 minutes to an hour. Can you imagine that? You live in a city that is incredibly small, and it could take you 45 to 60 minutes using public transportation to access a specialist. So if you don't have access to broadband in a large metropolitan city, you don't have the ability to reach those subspecialists you need to reach in order to be able to manage your care. That's why broadband is so important, not only about having access, but it being affordable and having the ability to have sufficient broadband in order to be able to optimize these solutions. Rural America, it's a fiber issue, right? We need to lay more fiber and to ensure that folks and families and individuals have access. And when they have access to high-speed broadband. Because what we have found out during the pandemic, and I'll put this article in the chat, is that broadband has been correlated, recent analysis has been correlated with certain mortalities during COVID-19, the pandemic. So if you didn't have access to broadband, it potentially has led to some deaths during the pandemic that could have been avoided if folks had access and could reach a doctor to receive their care. The other piece I wanted to highlight is an FCC analysis that chronicled the digital divide. So it looked at urban access versus rural access. And the digital divide is the highest in Arizona. And typically with the southern states that don't have sufficient funding to support broadband initiatives. And it was 87.5% for urban areas in Arizona and 45.4% in rural areas in Arizona. The state with the lowest disparity between broadband was Connecticut, where urban access was around almost 100%. Rural access was roughly around 99.6%. And in the state of Pennsylvania, urban access is 95.4% and rural access is 85%. So I want to conclude my comments by saying that broadband is hyper local. And the states that have made the biggest broadband gains typically have dedicated funding programs that turned out to have greater positive impacts on getting more people connected to broadband. So we can't simply look at this as an urban and rural argument. It really is a hyper local argument in discussion about how states are funding these broadband programs, urban, suburban, and rural areas. And really, what is the funding mechanism devoted to supporting these programs at scale?
Yeah, that's a fantastic point, because I think sometimes we overgeneralize and simplify, and I think you've done a great job of really pointing out the nuances of the issue. And something I probably should have started off with, and I know Dr. Hearn in his presentation talked about the social determinants of health. And some people understand what that is, some people may not. So Dr. Thacker, could you talk a little bit about what is the social determinant of health and why broadband connectivity is a social determinant of health? We make assumptions, but it would be good to sort of talk through just what those things are and why broadband connectivity and social determinants cross paths.
Sure. Thanks, Renee. And in many ways, my some of my comments might draw from what others have already said before. So I'll keep my comments brief so that I'm not repeating. So I think first, definitions matter, but I would suggest even before definitions, historical perspective also matters. And so these days, as a public health professional, as a health services researcher, I keep myself grounded in historical perspective and definition. So there are lots of definitions. I would suggest, and I should have mentioned this in my introductory remarks, that I am an immigrant to the US. I have spent more of my life in the US than in the country of my birth, which is India. The reason I'm bringing this up is because as an immigrant, one of the aspects of America I've come to really appreciate, admire, but also sometimes I find myself confused by is how easy it is to forget history. So I'm saying all this just to, suggest to all of us that social determinants of health, while that's a term we hear a lot about these days, and that might make us want to think it's something new or something that we don't know about, I would suggest it's a term that's very well known to all of us, not just to the researchers or policymakers or to the providers, so on and so forth, but really all of us. There is a lot of massive amount of literature on social determinants of health. It comes from excellent work that many have done in our country, and a lot of work that's also being done outside of our country. There are many definitions, so that's another place I always remind myself. We love being innovative, so there are lots of definitions of social determinants of health. The one I try to use, I find it works for me, is, and I'm going to read here and then happy to put a link in the chat, is social determinants of health are conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. I'm reading this verbatim. It comes from Healthy People 2030. My understanding is many of us have heard about Healthy People 2030, and probably some of us have not heard. So I would put a link in the chat. Healthy People 2030 currently groups social determinants of health in 5 domains, and they are 5, I would suggest, interrelated and connected domains. So one is education, access, and quality. The other is the one that many of us have touched on, healthcare access and quality. The third is economic stability. Fourth is social and community context. And the 5th is neighborhood and built environment. And I want to go back to some remarks that David made earlier. Currently, in this conceptualization, in these 5 domains, internet connectivity is measured, is conceptualized, is thought about within multiple constructs. It comes within healthcare access and quality, as you would imagine and expect. And then it also is mentioned, talked about, measured, tracked under neighborhood and built environment. So, with those 5 domains, there are multiple definitions. World Health Organization has a conceptualization. There are, just unbelievable amount of literature, especially in the last 3 years. The breadth and the depth of literature on the topic of social determinants of health has become, just mushroomed, exponentially grown. It's tied to many things, including the inequities in our country, whether it's inequities, within health and healthcare, or within education, within economic stability, within social and community context, or in the neighborhoods and built environment we live. So inequities in our country, inequalities in our country, we can argue about the extent of those, but there is a tremendous amount of evidence that supports that inequities and inequalities remain, they are growing, and also something can be done about it. So in that context, the focus on social determinants of health has increased a great deal. Literature has been generated, scientific evidence has emerged. I think to your question on broadband connectivity, I want to go back to what David was mentioning. So right now, broadband connectivity is conceptualized within many of these domains that I mentioned. I would suggest, and it's not an original thought, it's not my personal thought, there's a lot of evidence supporting this, that broadband connectivity is indeed a social determinant of health. And rather than quote evidence, I think I will take maybe a minute or two to just describe a personal example from someone I know. A person, 76-year-old woman, she sees herself, she has multiple roles. She's a mother, she's a wife, she's an immigrant, she's a sister, she's a neighbor, she happens to believe in God, so she is a God's child, so on and so forth. So you can imagine the different roles she plays, the identities she has on any given day. So her life, from the minute she wakes up to the minute she goes to sleep, each of the activities she does at home, outside home, in these various roles, is enabled by broadband connectivity. She talks to a daughter that's in India, the country of her birth, and she uses technology, broadband-enabled device, to talk with her daughter, stay connected with her. That energizes her, encourages her, helps her health, her well-being. She talks to the neighbors to stay in touch with them, and uses a broadband-enabled device to do that. So that's the neighborhood and built environment, just as an example. During the past 2.5 years, she was monitoring information about how her county is doing, how her neighborhood is doing, whether it's safe for her spouse to go to work, whether there is indication to wear a mask, whether vaccinations are available, whether vaccination for COVID-19 are effective. What does that mean? What information she needs, how to protect herself, how to protect her health, so on and so forth. And for all of that, here is a person who relied on information that was enabled because of technology, information that allowed her to make some sound decisions, some not so sound decisions, but continue to adapt to the changing life, which I would suggest all of our lives continually change. But in the last couple of years, she had to adapt continually to actually be resilient and survive the context, but also thrive, feel empowered as a person to make sound decisions for herself, her family, her neighbors, so on and so forth. So hopefully that example, and I would suggest, bringing back to what we are engaged in here, we are all learning right now. We are, some of us are at work, so we are working right now. Some of us might be right now exercising and listening to this. So we might be, or we are playing with our family, so on and so forth. So my point is, we can see an example that a session like this cannot be happening if we didn't have access to broadband connectivity. So with that, hopefully, rather than present a lot of research evidence, which there is plenty, I'm hoping that those two examples help us at least have a sense of, and I invite the audience, I'm sure each of you have examples as well, and perspectives on one, whether broadband connectivity is a social determinant of health, but also, how it affects where you are born, where you live, where you learn, where you work, where you play, where you worship, and where you age, and how you accomplish all that and then thrive to maintain good health, good well-being, maintain high quality of life, and minimize risks. So back to you, Renee.
I love the personalization of it because it brings it home. And it reminds me, earlier this year, we were the market for a home. It boiled down to two homes. One had broadband connectivity and one did not. And that was one of the main factors why we went with one house over the other. It really impacts all of it. So I think that those examples are phenomenal. Bring it home. Just a point of order here, Michael Crawford had to sign off. He apologizes for having to leave early. An emergency came up, so he will not be with us in the remaining 15 minutes. And before I go back to our panelists, I'm wondering, I know we have a special guest from HHS, Ms. Meckler, and I wonder if she would like to speak to the group about the issues we've been discussing. I don't want to put her on the spot, but Ms. Meckler, I hope I'm great.
Thanks so much for the opportunity to join this afternoon and to listen in and reflect on some of what we've heard. I'm Samantha Meckler. I'm a policy analyst in our Office of Policy in the Office of the National Coordinator for Health IT, which is often referred to as ONC. And we are a shop within the Federal Department of Health and Human Services. And our primary responsibility is really charged with offering federal coordination for advancing health IT for the nation. So we really recognize that health IT alone can't address all of the societal and institutional factors that drive inequities in the US today. And so a lot of our work, while we're focused on health IT data and standards, we also importantly focus on policy and infrastructure and implementation. And so really appreciate the opportunity to join you in the community today to listen to so many of the other distinguished speakers that are here, talking about the partnerships, the challenges, the work that they've done, particularly with the opportunity, that some of the challenges of the pandemic presented to address equity with leaders and build stronger partnerships. So just want to thank you for sharing your stories and just offer that, telehealth, social determinants of health really cuts across all of the agencies in the federal space. So we at ONC really do have the honor to support many of our federal partners in this space, whether we do that through some of our coordinating functioning work, but there are many resources available to support communities when you're looking at telehealth and infrastructure investments. I'll put some of those resources in the chats for folks to explore. And then also working with our federal partners, with stakeholders, with communities, and supporting communities with the exchange and use of important health data that is not just clinical health data, but really looking at broader health data such as the social determinants of health so that it can be captured, exchanged, and used to support holistic, person-centered health and care for individuals and communities, not just in clinical healthcare systems, but really strengthening and enabling that data to flow for individuals and communities in many of the institutions that are part of your alliance that are really focused on what are some of the strategic next steps. So I will put a bunch of the resources that we have available from our space in the chat so that you can explore and look at how we are aiming to support communities and their exchange of social determinants of health, and then also some of the broader federal resources for those of you that are interested in looking at funding opportunities as well. So thanks so much for the opportunity to offer just a few remarks this afternoon as part of your discussion.
Thank you very much, Ms. Meckler. Very much appreciated. And even though I'm in this space, sometimes it amazes me how many resources actually exist that we don't know about and how many different parts of government are actually working on these issues. So very timely and appreciated. And please be on the lookout in your chats for a lot of this information. I know that Michael uploaded a link to some of the statistics he was talking about earlier. Dr. Broadband, some folks want some information from you. Maybe we can follow up after this meeting with some links and some information to follow up. But there's a question in the chat, and I'll go to you, Dr. Broadband. You sort of talked about it a little bit with Medicare. What role do health insurers play in the access issues and increasing digital adoption? I know Medicare has obviously a role, Medicaid. What about private insurers as well? Maybe we could talk about that a little bit.
Well, for us as a health system, and for our patients that we serve, we want a relatively unified process by which we can integrate telehealth. You know, it broke my heart to be able to, I mean, it breaks my heart prior to the pandemic to be able to provide services to Medicaid beneficiaries, and I couldn't provide the same service to an urban Medicare beneficiary, right? I mean, these were real challenges in terms of how a system can adopt new technology and new models of care. Our goal is to align the payment processes as much as possible. It did take legislation in Virginia for the commercial payers, and that was in 2010, so quite some time ago. But it took legislation for them to be able to pay for telemedicine services. Anthem Blue Cross Blue Shield had given us a grant, and when our grant expired, we said, look at the great work we've done for your enrollees. And they were like, well, we're not going to renew the grant. So one of our legislators in the Commonwealth of Virginia stepped up and introduced that legislation. I was fortunate to serve on the board of Virginia Medicaid. And so we were very lucky to have a voice within Medicaid. But in Virginia, again, it takes legislation for the Medicaid, the states really control a fair amount of Medicaid activity and the policies. And so we had to have legislation introduced. And I'm happy, I will send Dave a list of all the bills that we passed both prior to and following the public health emergency. But it is a partnership. And I truly mean that. A partnership with our legislators has been imperative. And I will also say that it was important for us to have the evidence at hand, the data that showed that it was cost effective, that it improved access, and that we didn't increase costs. That's always a challenge, you know, with any bill that goes before Congress, right? The Congressional Budget Office scores these bills. So, you know, again, it's important to have the data, to have the evidence, and to work both at the federal and state policy level. And I'm really hopeful that a legislation will come forward that will make changes permanent in the 1834M restrictions in the Social Security Act to enable coverage for anybody with insurance to receive telemedicine services.
No, that's a very good point. And I know we're coming up on time. One thing that occurs to me, everybody is talking about how the pandemic catalyzed a lot of the innovation, the use. I know, Dr. Raban, you've been involved in telemedicine for decades, and I know you used to have to explain what that was. You don't have to do that anymore. But is there a concern that we could, I think Michael talked about traffic and regression to the mean. Is there a concern that we will regress to the mean and a lot of the advances we've seen over the last 3 years may slowly dissipate back to maybe not where it was prior to the pandemic, but not where it needs to be?
Well, certainly, again, when if the policies are aligned, healthcare providers and systems will support continuous use of telemedicine. That's why we don't want anybody falling off that telemedicine cliff at the sunset of the public health emergency. Currently, by statute, Medicare will continue the waivers for 151 days following the sunset of the public health emergency for us to hopefully get legislation that will allow us that we'll have time for CMS to gather the data, right? And then for legislation to pass that will make permanent some of these changes. I can't emphasize enough. And, you know, at the state level, it's the Department of Planning and Budget scores every bill. At the federal level, it's the Congressional Budget Office. So the more that we can do, without question, we already have gone back. I mean, people have been vaccinated. We know how to manage infectious diseases better, and certainly COVID-19. So whereas we might also have been at 50% or 70% of our patients were seen virtually, we're now back to less than 10%. But we'll right size it. The market will figure out a process by which, and innovators will find a process by which it's right size. But virtual care is certainly here to stay. We just want to make sure that all beneficiaries, all insured, all Americans have access to the benefits of virtual care. So I don't think it's absolutely not going away, but it behooves us to create policies that will enable continuous innovation and the development of evidence that supports continuous care via a whole host of technologies. AI assisted technologies, that's another great space that we're moving into. And then on the AMA side, I with Dr. Kavadar, I co-chair the AMA's Digital Medicine Payment Advisory Group that creates the that creates the models, that creates the CPT codes approved by the CPT Advisory Committee, valued by the RUC Committee, and then adopted by CMS. It's important that we do this all together, and we are bound by evidence, sincere evidence, and publish in the peer-reviewed literature as well.
Amen to that. Mindful of time, please keep checking your chats. There are a lot of great and useful links being posted. Dr. Ahern, I see your hand is up. Please ask your question.
Yes, Renee, if I may, thank you for this great panel. I wanted to bring it back to social determinants of health as a domain. I think to the extent that we can build the case that elevating this discussion such that that broadband connectivity is a social determinant of health domain will enable greater policy, have greater policy influence, where we can say, we believe there's a business case, there's a value proposition to elevate it to its own domain. It has economic prosperity considerations. It just is such a super determinant that we need to make that case, which in turn I think will help mitigate any slipping back to the old ways of doing things, both in terms of care and in terms of health. So that's sort of the case we want to try to make, and we want to work collaboratively with our partners to do it. One final point I make around Berks County is I think about the economic prosperity dimension of broadband connectivity, how important that is at the local level to kind of raise up the prosperity of constituents in a county. Having broadband access increases access to employment opportunity, increases access to delivering care to the home. I mean, all of these things have tremendous economic implications. So I think there's a lot of value proposition discussion we want to have around this topic.
That is such a wonderful point. I mean, very, very well said. And I think you're right. I think what you say could also drive policy, particularly on Capitol Hill, when it comes to some of these issues. Back to our panelists. So Karen and Dr. Thacker, if you could just take 1 minute with some closing thoughts, and then I'll turn it back over to David. We'll start with Dr. Thacker.
Sure. First of all, thank you for having me as part of this conversation. Delighted to be here. I think this is one of the conversation I'm hoping will continue beyond. So thank you to all in Berks County, most definitely. I do want to recognize Berks County as I understand, a leader. As I mentioned earlier, I'm trained as a researcher, so I call it Google my life away sometimes. So I just was trying to learn about Berks County, have never been there, but did want to understand the context. And so I came across an announcement that said Berks County in the a specific population category, and I'm looking on the other side because I'm reading off of. So Berks County was number 10 in digital counties survey. So there is a survey. I bet Dave, you from Berks County know all about it. I did look at your county, the way you are systematically approaching the thinking about and the planning, and hence the execution of improving connectivity and digital literacy, which I know we have touched on some, but that's really, really critical. So just delighted to be here. I think the last statement I want to share here is just the unbelievable confidence I have in the people of our country. I've seen this, over and over again. I know it's a broad comment to make from the, perspective that I bring, but I believe people use what is useful, and people will continue to use what is now available and will continue to use that to improve their health and well-being. I have full confidence in that. So I am not concerned about slippage. And I think there are a lot of levers, policy programs, collaboration across individuals, across organizations. All of that, I'm confident, will continue and be enabled by broadband to help us improve health and well-being for all Americans. Thank you.
Thank you. Dr. Raban, some final thoughts from you.
I'm so grateful for the opportunity to join you today. It's wonderful that Berks County has done this. Community conversations are critical. I also, I put in the chat, and Dr. Meckler did as well. So University of Virginia is the home of the Mid-Atlantic Telehealth Resource Center. So we serve the Commonwealth of Pennsylvania. And I put our website in there. So we'd be happy to continue with discussions and help you in any way. Telehealth is here to stay. Virtual care is here to stay. We just need to make it work for everyone. Thank you.
Excellent. Want to thank our wonderful panelists. What an incredibly engaging and enriching conversation. Thank you to Dr. Ahern for his presentation at the top. And of course, David, thank you for providing this opportunity for this discussion. Please keep checking the chat. There's a lot of wonderful information being linked there. And I'm going to turn it back to you, David.
Great. Thank you, Renee. This is a fantastic program. We really appreciate your leadership on this and the presentations of the people. It's just very inspiring for us here in Berks County. Dr. Ahern, thank you as well for your presentation. This is a challenge, but an opportunity. And I think we're beginning to understand that it is an opportunity here in Berks County. And this has really given us a good platform to begin to work off of. So thank you very much. Thank you, everybody, for joining us today. We will be sharing the comments and questions with everybody, as well as the video. And I think we're going to try to send the video to even more people than the ones who registered for this event, because it is so important, so valuable. Also want to thank people at the FCC and the people at HHS who helped us do this program. So we appreciate your ability to support us in this as well. This has just been fantastic, just really fantastic. So thank you very much. And everybody enjoy the rest of your interesting and beautiful fall day.
Thank
Thanks,
you.
everybody.
I know.